All right, this week we got Parkinson's disease, and I ended up grabbing the catch-all bag of leftovers from the case. So what that means essentially is I'm going to talk about everything elderly: vaccines, prostate, blood pressure, presbyopia. So what vaccines does an elderly person need? In order to understand that, let's just talk about vaccines that everybody needs, all right? Except I didn't include children because that list is really long. But every adult needs to get a tetanus and diphtheria every 10 years. Add pertussis to that if you didn't receive one when you're a child. And so just get your booster shot every 10 years. And that's going to include elderly, not elderly, everybody. Get an annual influenza. It's recommended. Of course, this year, I don't know what the number is, but it's only working about 20 to 25% effective compared to previous years. Adults, of course, you're going to get the all adults, but also you're going to get the HPV, hopefully, and you're going to get, HPV vaccine is recommended for women up to age 26, men up to 21, and men who have sex with other men up to age 26. Then you also get vaccines based on exposure. So health workers, military, for example, I had to get smallpox and anthrax and a bunch of others. If you live in dorms, you're supposed to get a vaccine for various causes of meningitis. And then now we're at over age of 60. Over the age of 60, you want to redo your shingles vax, your zoster vax, because shingles is a really common thing in adults over 60. Reactivation of varicella zoster is what happens. And then pneumococcal vaccine age 65 or more, and this is because they have an increased incidence, statistical increased incidence with lung involvement from pneumococcal diseases. So pneumococcal pneumonia and that kind of thing. Then, okay, healthcare workers. This is going to be us. Hepatitis B, MMR, varicella for chickenpox, and meningococcal. Now let's talk about prostate screening. This is probably the most controversial medical thing I have ever seen. And I've just finished reading about it for like 2 hours and still don't have really a good idea on what I should do as a healthcare provider. But guys, we have a lifetime risk of prostate cancer of about 16%. And out of all of us, even the ones that do and don't get prostate cancer, all of us combined, we have a death risk of 3%. 3% of men die from prostate cancer. So imagine that we used PSA to diagnose 48 people with prostate cancer. Imagine that's what we got using PSA alone, or PSA with some other digital rectal exam or something. Then we would only save one additional person. And that's because a lot of the people that get prostate cancer, it never affects them, never causes them to have clinical symptoms. Some of them get some clinical symptoms, morbidity without mortality, and then a smaller percentage of people will actually have died from prostate cancer. But the people that die, so like I said, lifetime risk of getting it 16%, death risk 3%. So the number of people that you have to diagnose to stop a death is quite a few. And then the fact that some deaths just can't be stopped regardless of whether you catch it or not. So you have to diagnose 48 additional people to save one person. And then the bigger problem is that if you do diagnose it early, you get a significant decrease in your quality of life. For example, doing a prostate biopsy and receiving all the treatment for prostate cancer, having prostate removed, that kind of thing, those things can cause some serious things like erectile dysfunction. And I really don't want to get that. And the fact that I got erectile dysfunction for treating my prostate cancer and I might not have ever died from the prostate cancer to begin with, I don't know if it's worth it. No, in all actuality, to be honest, there are a lot of morbidities from the diagnosis and treatment of prostate cancer. And so, out of all of the sources that I read, most of them did not make a recommendation on whether or not to test for prostate-specific antigen. And there's a bunch of reasons. First of all, it's going to have to be an extensive discussion with your patient. So, you need to get patient autonomy involved in this kind of a decision. They need to have some informed consent. So if they're going to have the test, they need to be really informed on what's going on. And a lot of people, once they've made informed consent, once they've been informed about the decision and they've used various algorithms of decision making, more people decide to not test. So if you do decide to test, then you have a couple other problems. What is the cutoff for prostate-specific antigen? Your prostate's making this antigen but in a healthy and in an unhealthy condition, and then the hypothesis is that a problem or a pathogenic state of the prostate will cause it to produce more. So if you have, for example, more cells in the prostate, a malignancy of such, then you'll produce more of this prostate-specific antigen. So then what's the cutoff for PSA? And then do I use a digital rectal exam with that, or do I just use a digital rectal exam without a PSA? What about ultrasonography? Do I do a rectal ultrasonogram, or is a transrectal ultrasonography recommended or not? So we have numbers on sensitivity and specificity, but there's even problems with those numbers because most biopsies are not done unless there's also an indication from a digital rectal exam. So this is going to cause an increase in sensitivity, or not really an increase, but an overestimation, and an underestimation of specificity. So what is this estimation, whether or not it's over or underestimated? What is the sensitivity? So the sensitivity, if you use 4 nanograms per milliliter as the cutoff for PSA, then the sensitivity is 21%. And it goes up to 51% for high-grade prostate cancer. If you use 3 nanograms per milliliter as your cutoff, then the sensitivity goes up to 32% and all the way up to 68% for high grade. So you can see it's not extremely sensitive, but for catching those high grade cancers, yeah, it's useful. However, how easy is it to treat a high-grade prostate cancer? So that's another problem. Then specificity. So for specificity, if we use 4 nanograms per milliliter as the cutoff, then it's got a specificity of 91%. And if we use 3 nanograms per milliliter as the cutoff, then it has a specificity of 85%. So things that cause the sensitivity to go up also cause the specificity to go down. Now let's talk positive predictive value. Positive predictive value, if you use 4 nanograms per milliliter as the cutoff, the positive predictive value is 30%. And if you use 10 nanograms per milliliter, then the positive predictive value goes up to 64%. What does this mean? If we use 4 nanograms per milliliter, then 1 out of every 3 biopsies will show cancer. If we use this, then about 2 out of every 3 biopsies will show cancer. The problem is, if we detect a cancer in this area, then it has a 75% cure rate. If we detect it in this area, it has a 50% cure rate. So increasing the positive predictive value decreases the cure rate. So you can see how different organizations and different groups of people and different clinics and different practices are going to have different ideas about what the best thing to do is. I found about 3 different sources with 3 different recommendations, and all of these came out within 2011 or later. One of them I found, for example, says if your PSA is between 2.5 and 4 nanograms per milliliter, then you should get it checked every year. If it was less than that, then every 2 years. And if it's greater than 4 nanograms per milliliter, then you should go for a transrectal ultrasound, or a biopsy. But you should correlate this with all of this with a digital rectal exam. But before you go and get your rubber gloves on, you need to be aware of a few things. What kind of things can artificially increase the prostate specific antigen. Or what things increase it? Well, prostate cancer increases it. What kind of things artificially increase it? One of those things is a rectal exam. So, as I have written here, the digital rectal exam will increase your PSA, and it'll increase it for about 2 days. And so each of these tests will increase the PSA by a different amount. And so the number of days that you have to wait before getting your PSA checked is different for each one. But going through the list, you have benign hyperplasia, subclinical inflammation. So if you don't know your prostate's inflamed, but it is, that'll cause an increase in PSA. A prostate biopsy, that makes sense. Cystoscopy, TERP, I don't even know what that is, but it does definitely sound like something that would increase your PSA. Urinary retention, make sure you're going to the bathroom. Ejaculation, so if you're active in your old age, guys, you got to slow it down for about 2 days before you get your prostate examined. And you might take into consideration, if you are active in your old age, that treating prostate cancer can cause you to be inactive. I'm talking about the old erectile dysfunction. Also, perennial trauma. So if you're riding a bike, you got to stop riding your bike in your old age for a certain number of days. So the half-life of PSA is approximately 2.2 days. And each of these things will increase the amount of PSA by different amounts. For example, the digital rectal exam increases it by 0.4 nanograms per milliliter. And if we're using 2.5 to 4 as our, say, let's recheck again, I don't want to get mine rechecked. I know there's already a base level, and if my base level is 2.2, I don't want it to be 2.6 by increasing it by 0.4. So let me get that thing checked before we get the digital rectal exam. And then for ejaculation, we'll increase levels by about 0.8. And then a prostate biopsy, which I have up here, increases it by about 7.9 nanograms per milliliter. So you can definitely see how getting a prostate biopsy before you get your PSA would not be a great thing. And this will keep it elevated for about 4 weeks. Let's talk about blood pressure now. Blood pressure is basically the same in all adults with one small exception. So the general rule for adults is the 120, 140, 160 for systolic and the 80, 90, 100 for diastolic. So what you do is you write out those three numbers, 120, 140, 160, and then you just put these words in here. So I'll put normal, pre-HTN, HTN 1, HTN 2. And so less than or equal to 120 is normal. Between 120 and 140 is pre-hypertensive. Between 140 and 160 is hypertension stage 1. 160 and up is stage 2 hypertension. And the same thing goes for the diastolic. So you do 80, 90, 100. And so this is normal range. This is pre-hypertension. This is hypertension stage 1. This is hypertension stage 2. And this is not an and, this is an either or. So if either your systolic or your diastolic is above a specific number, you go by the higher number. So if your systolic is 119 and your diastolic is 81, you're still pre-hypertensive. If your diastolic is 79 and your systolic is 140, then you're still, let's say 141, then you're still hypertensive, stage 1. So you always go by the one that's the highest in its range. Now, so the difference for the elderly, in normal people, we want to start treatment with pharmacological treatment at the 140 or the 90. For elderly, we start treatment at 150 or 90. And so the systolic rule just changes from 140 to 150. The 160 stays the same. However, one thing I read from 2012 said they recommend still 140 for pharmacological treatment. Now, these are all based on statistics of outcomes. So basically what it boils down to is, do you have an increased risk of cardiac or other pathologies from from a specific blood pressure level. And so some studies have indicated that the elderly age 60 or 60 to 65 and up will be okay with a blood pressure up to 150 for systolic, and other studies have shown that statistically anything over 140 you have increased risk. It's just not as much as in the general population. Now, I think it's also important to memorize that none of these numbers work for children. For children, I made a video on hypertension back in block 2, and you can go back and watch that to find out how you check the status of a hypertension in a child. Now, the treatment for hypertension, you're always going to begin with either a thiazide, calcium channel blocker, ACE inhibitor, or ARB. And the use of a beta blocker is only when MI and CHF are present, and still shouldn't be your first choice because you can use the beta blocker for the MI and CHF, but you should also maybe consider another drug to treat the hypertension if it's present. Some studies indicate that in the black population, thiazides and calcium channel blockers work better. However, in the non-black population, usually the ACE has been shown to outperform the other drugs in a lot of cases. However, thiazides are greater than calcium channel blockers for whenever strokes are possible, and thiazides are greater than ACE for the treatment whenever MI is possible. So if you have these risk factors, stroke or MI, then you don't want to start with an ACE. You want to start with a thiazide. So the thiazide diuretic, the ACE inhibitor, the calcium channel blocker, the ARB, they're all good, and it's going to be based on the clinical picture that you see for which treatment that you use. So let's talk about presbyopia. The word presbyter means elderly, and opia is talking about vision. So you're talking about the vision of the elderly. What happens? So typically, two common words that we know of are myopia and hyperopia. There's several other opia problems, but these are the two common ones. And so myopia is like nearsighted, hyperopia is farsighted. And so they are basically just refractive problems. What that means is that so here's our eye, and here's the cornea, and here's the lens, and here's where the retina is. And so light's coming in parallel, and then it gets focused on itself, and it focuses whenever it focuses in front of the retina, then it's myopia. And so the problem with myopia is that the axial length of the eye is too long. So myopia, say axial length is too long. And then with hyperopia, it's the opposite. So it comes in whenever it's refracted, it gets focused as if it were behind the retina. So the axial length is too short. So axial length too short. And this may be due to the eye being a little bit larger, or it may be due to the thickness of the lens, and so it's neither here nor there. Now, so what's presbyopia caused from? Presbyopia, if we make our eye a little bit bigger, and we have the retina coming in, and then we have some muscles right here and right here that are attached to zonular fibers, and these zonular fibers attached to a lens. And now whenever the zonular fibers are taut, it stretches the lens tight, and this allows you to focus on things that are far away. So far away, it comes in, it focuses. But whenever these loosen up, typically, if the zonular fibers are tight, they're going to be stretched. Whenever they loosen up, give you more slack, then it should allow the lens to be not stretched and essentially elastically shrink down. And this allows you to focus on things that are close. In presbyopia, the normal accommodation of the lens to shrink back down is gone away, and it's because of age process and things not working right due to age. And so what that means is that you can't focus on things closer than arm's length. So closer than arm's length. That's the rule of arm. You can't focus on those things. This typically presents itself around age 40, and so about age 40 you start getting problems seeing things nearby. You start feeling like, oh, I think I have a hyperopia, I'm farsighted. No, you're probably just presbyopic, and you need to get some reading glasses or something.